Hi, colleagues. This is Gilbert Morgan, and welcome to WeOncologists ESO Presents. Today, I have the extreme pleasure to introduce a good friend of mine, Dr. Madariaga. She is a medical oncologist trained in Madrid. She did her residency in Ramon y Cajal Hospital and worked as a staff in gynae and GU oncology in Gregorio Marañón Hospital in Madrid. From January 2018, she has been doing her fellowship in clinical and research in Princess Margaret Cancer Center in Toronto as part of the drug development program and gynecology site. She has a special interest in gynecological malignancies and rare tumors, and her current research areas include mucinous gynecological cancers and gynecological tumors in young and young adolescents. Doctor?
Hello, everyone from Canada. And thanks so much, Jill, for the invitation, for the amazing work that you are doing as part of ESMO Young Oncologist. And I would like also to thank ESO for the opportunity to talk about this topic, which is first-line treatment in ovarian cancer. Very exciting, with lots of changes in the last few years. So it's a pleasure to be here and give a talk about this. So the overview of what I will be talking about, I'll do a brief introduction about ovarian cancer and the changes according to histology. We'll talk about surgery, IV chemotherapy, IP treatment, and maintenance strategies. And I will try to focus a little bit more on changes according to histological subtype. So ovarian cancer is the most lethal gynecological malignancy in developed countries. It's diagnosed in advanced stage in around 75% of the cases, and the relative overall survival depends on the stage of diagnosis. It's very good in early stage, around 92%. However, in advanced stage, 5-year overall survival is less than 30%. There are some genomic predisposition syndromes that are related to epithelial ovarian cancer, although most of them are sporadic. 15 to 20% of the cases can be related to BRCA mutations, and these are more frequent in high-grade serous subtype, whereas Lynch syndrome can account for 10 to 15% of hereditary ovarian cancers and are more frequent in endometrioid subtype. So as discussed, we'll go into focus on epithelial ovarian cancer. There are 5 main subgroups. More frequent one is high-grade serous, and we'll talk a little bit also about endometrioid, low-grade serous, clear cell, and mucinous carcinomas. High-grade serous ovarian cancers are aggressive tumors with high proliferative rate. They are usually chemosensitive. However, with subsequent treatments, they can develop chemoresistance. An inherent characteristic of high-grade serous ovarian cancers is to have a TP53 mutation, which accounts for nearly 99% of the cases. Other important characteristics are BRCA mutations in around 15 to 20% of the cases, and homologous recombination related genes, which can appear in account for 50% of the cases, such as RAD51, ATM, Fanconi anemia, and BRIP1. Low-grade serous ovarian cancers are less common. They account for around 10% of epithelial ovarian cancers. They have a more indolent behavior and low proliferative rate. They are relatively chemoresistant, and they tend to express hormonal receptors. So hormonal treatment is a possible treatment for these tumors. BRAF mutations appear in around 40% of the cases and KRAS in 20%, and these are favorable prognostic factors. Clear cell ovarian cancer is also quite rare, accounting for only 5% of epithelial ovarian cancers. However, they are more frequent in other populations, such as the Japanese, where it can be around 25% of all the ovarian cancers. They can arise in the background of endometriosis. They are usually diagnosed in early stage, but have a poor prognosis and tend to be chemoresistant. ARID1A mutations are very frequent in clear cell carcinomas of the ovary, accounting for 50%, is the most frequent mutation in around 50% of the cases. PI3K pathway is also quite important. And there is a possible immune phenotype in clear cell carcinomas of the ovary with higher interleukin expression, and especially in those patients with clear cell carcinomas that are MSI high, there is a high TL and PDL1 expression. Clear cell carcinomas don't have any effective treatment at relapse. Some reports have reported response rates of less than 1% at relapse, and sometimes platinum-free interval is not a good surrogate to try to see which is the best treatment. So clinical trials are highly recommended for this subtype of cancer. Endometrioid ovarian cancers account for 10% of the cases. Low-grade endometrioid ovarian cancers share a similar profile as low-grade serous ovarian cancer, whereas high-grade have a similar profile of high-grade serous ovarian cancer. They can also arise in the background of endometriosis. Frequent mutations appear in PAK3CA, PTEN, ARID1A, and they may have MMR deficiency. They can also sometimes be related to Lynch syndrome. Finally, mucinous ovarian cancers are quite rare, accounting for around 2.5% of ovarian cancers. They are usually diagnosed in young patients, and they in early stage with very large tumors. It's important to rule out metastasis from GI origin in these cases. Overall survival in patients who relapse or have stage 3 or 4 disease is quite poor and can be around 1 year. They tend to be chemo-resistant, and although for decades we have been classifying mucinous cancers from grade 1 to 3, in 2014 WHO gave a new classification for mucinous cancers, and they should be classified currently as expansive where there is minimal or no stromal invasion, or infiltrative when there is destructive stromal invasion. KRAS mutation is an early event in mucinous ovarian cancers and can be found in mucinous borderline cancers. However, the other oncological alterations, such as HER2 amplifications and TP53, do appear later and are more frequent in the infiltrative subtype. As you can see in these curves, overall survival at stage 4 varies according to histology. That's why this represents that the different biology of different histological subtypes in ovarian cancer. Unfortunately, the treatment of different histological subtypes have been, most of the studies have been done in high-grade serous ovarian cancers, and we do the treatment in other histological subtypes according to that. However, it seems that the biology and the molecular profiling is different in these tumors. And this highlights the importance of having tissue to see which is the subtype and to try to tailor the treatment according to that. As you can see in the curves, high-grade serous and endometrioid histologies have a better overall survival, whereas clear cell and mucinous have a more poor outcome. Just to give an overview of the treatment in advanced stage ovarian cancer, the first question is whether surgery is feasible upfront. If surgery is not feasible, we normally tend to give neoadjuvant chemotherapy or clinical trials. And when surgery is feasible, that's the first step to do. And then we'll talk about adjuvant treatment following that. And here you can see the tree of questions in first-line ovarian cancer. The standard practice needs to take into account histology, stage, genomics, and residual disease. And there are still very important questions to be answered in each branch of the tree, as you can see, and we'll try to talk about that in the talk. So first step, as we said, is surgery, an assessment for debulking surgery. This should be done by a qualified gynecology surgeon, and the goal of primary cytoreduction is R0, complete removal of all macroscopic tumors. Only patients that are amenable to achieve optimal resection should be offered primary cytoreductive surgery. And we need to keep in mind that R0 resection is the most important prognostic factor in primary debulking surgery. Trying to see the how extensive the surgery should be, this trial has been recently published, assessing the role of full pelvic and paraortic lymph node dissection in stage 3 and 4, stage 2 to 4 epithelial ovarian cancer. In this trial, patients who had non-enlarged lymph nodes in surgery were included, so patients were highly selected, and only those with non-enlarged lymph nodes were included in this trial, and they were randomized to receive systemic lymphadenectomy versus no lymphadenectomy. 90% of the patients received bilateral salpingo-oophorectomy, total abdominal hysterectomy, omentectomy, and peritonectomy. GI resections were done in 50% of the patients, and the medium lymph node resection was 57. As you can see in the curves, there was no difference in overall survival and PFS in both subgroups. However, 55% of the patients had lymph node metastasis, had microscopic metastasis in the lymph node group. Despite that, there were no differences in PFS or overall survival. The lymphadenectomy group was associated with high morbidity and higher mortality. However, with this trial, we need to keep in mind that all the patients had normal lymph nodes at the time of surgery. This doesn't mean that we don't need to do a lymphadenectomy in all patients. So trying to, as we know that R0 resection is really important and is one of the most important prognostic factors, trying to improve that, several trials assessing neoadjuvant treatment have been done. Here you can see the two main phase 3 randomized trials assessing primary debulking surgery followed by 6 cycles of chemotherapy versus 3 cycles of neoadjuvant chemotherapy followed by interval debulking surgery followed by 3 more cycles of chemotherapy. Patients with stage 3 and 4 cancers were included in both trials, and there were no differences in either overall survival or PFS in any of the trials. However, these trials have been criticized due to a low R0 resection rate. As you can see, it was only 40% in both trials, as well as quite low overall survival, which was 29 months in the EORTC trial and around 24 months in the CHORUS trial. Trying to answer these questions and whether giving neoadjuvant chemotherapy is the same as going for interval debulking surgery, TRUST trial is currently ongoing, where centers where more than 50% R0 resections are done are being selected. Pooled data of both trials has been published, and in subgroup analysis, it seemed that those with stage 3C cancer and small metastasis had a better PFS with primary debulking surgery, whereas those with stage 4 cancer had a better overall survival with interval debulking surgery. So, following surgery, the standard of care treatment in most of the centers is to give carboplatin and paclitaxel every 3 weeks IV. However, several attempts have been done to try to improve the outcomes, and several trials have been published assessing the role of dose-dense chemotherapy, giving paclitaxel weekly. The first trial is the Japanese trial, GOG 3016, which assessed a 3-weekly chemotherapy versus 3-weekly carboplatin along with Taxol given once weekly. Overall survival and PFS were significantly improved in the dose-dense regimen, and overall survival was 100 months in the dose-dense regimen versus 62 months in the standard of care 3-weekly regimen with a hazard ratio of 0.79. Regarding side effects, although more anemia was seen in the dose-dense regimen, no differences in neurotoxicity were seen. However, other trials have been done following this one in European and American populations, and these differences have not been seen. This may highlight a different pharmacogenomic characteristic of the Japanese population comparing it to the Caucasian population. The second trial is GOG 262, where patients were randomized with the same, this was done in America, the patients in American Korea, patients were randomized to receive a standard of care 3-weekly chemotherapy versus a dose-dense regimen with paclitaxel given weekly. 84% of the patients received bevacizumab, and there were no significant difference in PFS or overall survival. However, in subgroup analysis, those patients who did not receive bevacizumab had a PFS improvement of around 3 months. Trying to answer that question, another 2 European trials have been done. MITO7 incorporated a different dose-dense regimen. The dose intensity of Taxol was lower at 60 milligrams per square meter, whereas in the rest of the trials were 80, and carboplatin was administered at an AUC of 2, also weekly. This trial did not show any differences in PFS or overall survival. However, the tolerance of the weekly regimen was better, with lower hematological toxicity and lower neurotoxicity. Trying to finally answer these questions, ICON 8 was presented in ESMO 2017, and this is the largest trial, including 1,500 patients, and patients were randomized to receive standard of care chemotherapy every 3 weeks versus carbo every 3 weeks and Taxol at 80 milligrams per square meter weekly, or both at dose-dense regimen with carboplatin AUC2 and Taxol 80 milligrams weekly. The trial did not show any differences along the 3 arms, and current standard of care in most of the centers continues to be the 3-weekly regimen. So trying to improve the outcome of these patients, other attempts have been done, including the administration of intraperitoneal chemotherapy. IP chemotherapy has a strong rationale. We know that ovarian cancer tends to metastasize in the peritoneal cavity, in the surface of peritoneal cavity, and with the administration of IP chemotherapy, we can achieve a higher concentration in that area. Cisplatin concentration can increase by 20 times in the intraperitoneal cavity when given with an IP port. It has a longer half-life in the peritoneal and a longer systemic exposure. 3 large GOG trials have been done in this setting, and they have shown a decrease in death in around 20 to 30%. However, these trials have been criticized for several reasons. The first GOG 104 trial did not include paclitaxel, which is current standard of care and was done with cisplatin. In GOG 114 trial, patients receive higher chemotherapy, more chemotherapy in the IP arm. So we need to have into account that the IP arm received 2 cycles of carboplatin at an AUC of 9 before starting with the rest of the IP treatment. So we don't know whether the improvement in survival is due to the more chemotherapy that was given in that arm. And finally, the GOG 172 trial, we will further discuss that in the next slide. But in these trials, patients received Taxol and cisplatin IV versus Taxol IV and cisplatin and Taxol IP. The IP dosage of cisplatin was higher, and there was an extra dosage of paclitaxel in day 8 given in the IP arm. So they also received more chemotherapy in the IP arm. This trial showed an improvement in overall survival of 65 months in the IP arm versus 49 months in the IV arm, which was significant. However, toxicity was quite high in the IP chemotherapy arm, and only 42% of the patients received the 6 planned IP treatments. This trial led to a NCI broadcast, led to the NCI to broadcast an alert in January 2006 to promote the IP chemotherapy treatment. A Cochrane meta-analysis was done with 9 trials, including these 3 positive trials, which showed an improvement in overall survival. However, this meta-analysis did not include the GOG 252 clinical trial, which was presented in SGO in 2016. Final publication is still pending. In this trial, IV chemotherapy, IP with cisplatin, and IP with carboplatin were compared, and patients with dose-dense paclitaxel and bevacizumab, and it showed no difference along the three arms. We'll focus a little bit more on that on the next slides. Something that we need to keep in mind is that IP chemotherapy trials have been designed in patients with stage 3 disease and optimal surgery with less than 1 centimeter gross residual disease. And stage 4 cancers are not included in IP trials, although in some centers they are used. So focusing a little bit more on the two main trials, which is GOG 172, as discussed previously, the IP chemotherapy arm received a higher dose of cisplatin. IV was 75, IP was 100, and an extra dose of paclitaxel on day 8, which was IP. And the paclitaxel was administered at a 24-hour infusion, which is not the current standard of care. The results, as discussed previously, quite significant overall survival difference, 49 months in the IV arm versus 65 months in the IP arm with a hazard ratio of 0.75. And then the GOG 252 trial, which was presented in SGO, assessing the 3 different regimens with IP cisplatin, IP carboplatin, and or IV chemotherapy, along with dose-dense paclitaxel and bevacizumab. In this trial, as discussed, no differences in PFS were found. Overall survival data has not been reported yet, like the differences. And this trial has led to some centers not to widely accept the IP chemotherapy, and some centers have stopped doing IP chemotherapy following GOG 252 results. This maybe the addition of new drugs such as bevacizumab decreases the effect of IP chemotherapy, and we need to have in mind that this is a toxic regimen with more inconveniences and with possible complications related to the catheter. Moving on with intraperitoneal treatment, several trials with HIPEC, which involves giving the chemotherapy intraperitoneally with heat, are ongoing. Giving heat along with chemotherapy can increase the cytotoxic effect of chemotherapy and can enhance the effect of DNA damaging agents. It has been shown in preclinical data that hyperthermia can inhibit homologous recombination DNA repair by BRCA2 degradation, and possibly patients with BRCA mutations might have a higher effect of HIPEC treatment. However, this needs to be seen. This is only preclinical data. So a trial has been published assessing in those patients who were not amenable for upfront debulking surgery. They received 3 cycles of carboplatin and paclitaxel, and they were randomized at the time of surgery. This is important that they were randomized at the time of surgery. And only those patients who were expected to have optimal or complete surgery participated in the trial. They were randomized to receive only interval debulking surgery or interval debulking surgery with HIPEC with cisplatin at 40 degrees. Following the treatment, they received 3 cycles of carboplatin and paclitaxel. And here you can see the overall survival and PFS curves, which were which is significant differences favoring the IP arm. Overall survival was had around 10-month difference with a hazard ratio of 0.67. Regarding side effects, HIPEC treatment was not associated with higher toxicity, and quality of life was also maintained in both arms. Regarding the trial, it has been criticized because an extra chemotherapy dosage is given in the HIPEC arm, so we don't know if that's the reason of the better outcome of the HIPEC arm. It has also been criticized not to because the expected PFS in the statistical analysis was 18 months, and the control arm only had 10 months of PFS, and Several trials are currently ongoing and trying to assess these questions. There are multiple trials in frontline and recurrent disease who will help us answer this question, but currently remains a little bit controversial. So regarding, we know that ovarian cancer tends to recur, and 70% of the patients recur. So trying to improve the outcomes, we are looking into trials assessing maintenance treatments, and different strategies have been done to try to do that, including anti-angiogenics and PARP inhibitors, but there are some concepts that I would like to highlight before going into maintenance treatments. One is the type of maintenance. So patients can go into continuation maintenance, which means adding a new drug to the chemotherapy and continuing with that drug as a maintenance treatment, or switch maintenance, which means you do your chemotherapy. If you have a response, you're randomized and you receive the investigational arm or not. We need to keep in mind that in those patients who have a switch maintenance, there is a gap of around 8 weeks from the end of treatment to randomization. And there is a high selection bias, because only patients with complete or partial response will go into the maintenance arm. Another important concept in a maintenance trial is that overall survival is sometimes difficult to assess and takes a longer time. So we need more surrogates apart from PFS in these trials assessing maintenance treatment. Of course, overall survival and quality of life are the best, but sometimes we don't see, we need a long time to assess overall survival, so that's why. An important concept that I will talk about later again is PFS2, which means time from randomization to progression on second-line therapy. And this reflects the disease control and effect on maintenance treatments in subsequent lines. Another two important concepts are TFST, time to first subsequent therapy or death, and TSST, time to second subsequent therapy or death. And this is especially useful when a regular tumor assessment until second progression is not feasible. It's really important to understand the relevance of a meaningful PFS, and these concepts help us with that. So assessing maintenance treatments in ovarian cancer, the first trial is assessing the continuation of chemotherapy, like a consolidation with more paclitaxel. In this trial, patients with stage 3 or 4 epithelial ovarian cancer were included, and they received 5 to 6 cycles of carbotaxol. If they had a complete response to the treatment, they were randomized to receive either 12 cycles of paclitaxel every 28 days or 3 cycles of paclitaxel. So as you can see, there was a significant improvement in PFS, 22 months in the 12-course paclitaxel arm versus 14 months in the 3-course paclitaxel arm, and no differences in overall survival. There was higher toxicity as expected in the 12 cycles of paclitaxel arm, with more neurotoxicity and pain, and this treatment has not widely been accepted in for clinical practice. Following on the trials assessing anti-angiogenic treatments, there are two main trials assessing frontline bevacizumab. The first line is ICON-7 trial. Here, patients with stage 1, 2 high-risk features and stage 3 and 4 ovarian cancer were included, and they received bevacizumab along with the chemotherapy, followed by 12 cycles of maintenance bevacizumab at 7.5 milligrams per kilogram. In the overall population, there was a PFS improvement, a modest PFS improvement from 17 months to 19 months with a hazard ratio of 0.681. But there was a predefined high-risk subgroup assessed as part of the trial, which included patients with stage 4 or stage 3 with more than 1 centimeter residual disease. In this subgroup, there was a 5-month difference in PFS with a hazard ratio of 0.73. Overall survival data has also been published. In the overall population, there were no differences. However, in the predefined high-risk subgroup, there was a median overall survival difference of 9 months, favoring the bevacizumab arm, with a restricted mean survival difference of around 5 months, which was statistically significant. The other trial assessing frontline bevacizumab is GOG-0218. In this trial, there were 3 different arms, and patients with stage 3 and 4 ovarian cancer, not the stage 1 and 2 like in the other one, only 3 and 4 were included. They could receive either standard of care chemotherapy along with bevacizumab without a maintenance treatment, or chemotherapy along with bevacizumab followed by a maintenance bevacizumab treatment. In this case, the bevacizumab was given at 50 milligrams per kilogram, whereas in the prior trial was 7.5. So regarding PFS, comparing the control arm with the bevacizumab maintenance arm, there was a significant improvement of 4 months with a hazard ratio of 0.72. In subgroup analysis, the benefits seem to be higher in those patients with stage 4 disease. Overall survival data was presented in ASCO last year and will shortly be published. It showed in those patients with stage 4 disease, median overall survival in those not receiving any bevacizumab was 32 months, whereas it was 42 months in those with receiving the maintenance bevacizumab, which was statistically significant with a hazard ratio of around 0.7. This trial also highlights that giving bevacizumab along with chemotherapy is not enough, that a maintenance treatment is needed. And just to summarize the main differences of both trials, the bevacizumab dosage in GOG was higher at 15, ICON 7 at 7.5. The duration of bevacizumab was longer in GOG 218, which was 15 months versus 12 months in ICON 7. And the inclusion of patients was a little bit different, with 30% patients with stage 1 and 2 disease and high-risk features in ICON 7 trial. Residual disease was also different in both trials. In ICON 7, 53% of the patients had residual disease, whereas in GOG 218, 70% of the patients had residual disease more than 1 centimeter. However, the duration of bevacizumab is still not clear, and there are other trials currently going on, like comparing different bevacizumab duration schedules. And trying to answer that question, ROSIA phase 3B trial assessed the administration of bevacizumab for 36 cycles. This was found to be safe with low discontinuation profile, with low discontinuations. It had a PFS of around 25 months in the overall population, whereas in the high-risk subgroup with stage 4 or stage 3 disease with more than 1 centimeter residual disease, the PFS was around 18 months, which is very high for this population. However, it continues to be a question for how many cycles bevacizumab should be administered in first line. So other trials assessing antiangiogenics have been done in frontline ovarian cancer. The trial assessing pazopanib had a switch maintenance strategy, like pazopanib was given after the chemotherapy. It's a phase 3 randomized trial with patients with stage 2 and 4 cancer. It showed a PFS improvement from 12 months in the control arm versus 17.9 months in the investigational arm with a hazard ratio of 0.77. However, discontinuation rates were high, around 33%, and was found to be quite toxic. It has an NCCN recommendation of 2B. However, it's currently not licensed for ovarian cancer. Another trial assessing frontline antiangiogenics was done with nintedanib. This was a continuation maintenance. That means that nintedanib was given along with the chemotherapy followed by a maintenance treatment with the drug. There was a PFS difference of 1 month, which was statistically significant, but is currently not marketed for ovarian cancer. So, trying to focus now on PARP inhibitors, one important concept is the synthetic lethality concept. So we know that DNA damage can lead to single-strand breaks in DNA, and PARP enzymes have a special role in single-strand break repair. However, if a PARP inhibitor is given, this can inhibit the base excision repair, and continuous damage can lead to double-strand break, which is usually repaired by BRCA-dependent homologous recombination process. So in those patients with BRCA mutations that receive a PARP inhibitor, this can lead to DNA non-repair and cell death. This concept, the synthetic lethality concept, led to several trials assessing PARP inhibitors in ovarian cancer, and trial assessing frontline olaparib has been published in frontline setting. Most of the trials assessing PARP inhibitors were done in recurrent setting. So SOLO-1 trial included patients with high-grade serous or endometrioid histology and germline mesosomatic BRCA mutation. Only 2 patients had somatic mutations, but most of them were germline, and the germline was centrally checked. They had a stage 3 or 4 disease and a complete or partial response to platinum-based chemotherapy. Patients were randomized to receive olaparib, 300 milligrams BID. Those who had a complete response to the treatment stopped the olaparib after 2 years, and those who had evidence of disease to continue with the olaparib. And this trial showed, you can see the curves, which are amazing, showed according to PFS, so showed a 3-year 3-year rate of disease-free survival was 60% in the olaparib arm versus 27% in the placebo arm, which was statistically significant. Overall survival data is still immature, and for now there are no differences. PFS2 has also favors the olaparib arm, which is 75% in the olaparib arm versus 60% in the placebo arm, with a hazard ratio of 0.5. And regarding quality of life, there are non-clinically meaningful changes. The treatment with olaparib was deemed safe, and the main grade 3/4 AE was anemia. There was 1 case of AML. So this trial has changed current practice in ovarian cancer, and maintenance olaparib is highly recommended in those patients who harbor a BRCA mutation. Moreover, this highlights the importance of doing BRCA, of assessing BRCA mutations early. More trials are ongoing and we're soon going to have results of trials assessing PARP inhibitors regardless of BRCA mutations, and hopefully we'll have those results soon. So going back to the tree of questions in frontline ovarian cancer, as previously discussed, histology, residual disease, genetic changes need to make us think which is the best strategy. And I will try to focus now a little bit on more rare histological subtypes. There are several trials ongoing assessing combination of chemotherapy and anti-angiogenic checkpoint inhibitors and PARP inhibitors. And this will give us more information soon on how to best treat these patients. Regarding rare histological subtypes, we know that low-grade serous ovarian cancer have a higher expression of ER and PR. There is a retrospective MD Anderson study which assessed 200 patients with low-grade tumors, stage 2 and 4, with primary surgery that received primary surgery and chemotherapy. There was a PFS improvement for the favoring the hormonal treatment arm, which was 26 months in the observation arm versus 64 months in the hormonal treatment arm. You can see the curves here. However, in overall survival, there were no differences. This study, despite being retrospective, has changed clinical practice. And in lots of centers, hormonal treatment is administered as maintenance treatment following chemotherapy. However, this requires validation, and we also need to assess the optimal duration of hormonal therapy. Like in this trial, the median duration was 33 months, but we're still very behind comparing to breast cancer, and we need to assess all those questions. There is currently a phase 3 trial. I don't know if it's open already, but they are trying to open a phase 3 trial comparing chemotherapy versus hormonal treatment as adjuvant treatment. So maybe some of these patients could avoid chemotherapy in the future. So going back to other histologies, in clear cell cancers, as I said, they are quite common in Japanese population. The Japanese trial group made a phase 3 trial assessing cisplatin and irinotecan frontline versus carboplatin and paclitaxel, because there was some preclinical data saying that irinotecan might be more effective in this subgroup of patients, which was negative. Having in mind the poor prognosis of patients with clear cell carcinomas, I think that it's important to consider clinical trials, and especially consider clinical trials with checkpoint inhibitors. In relapse disease, a phase 2 trial assessing pembrolizumab showed that clear cell ovarian cancer might have a higher response rate comparing to other subtypes of ovarian cancer. And then going back to mucinous, also a frontline phase 3 trial was done assessing carboplatin and paclitaxel versus capecitabine and oxaliplatin plus minus bevacizumab. This study was closed early. However, due to slow accrual and these things that happen in rare tumors, however, preliminary results of 50 patients showed no differences between both regimens. And as discussed previously, it's important to know the subtype of mucinous ovarian cancers. And now it's not enough with grade 1 to 3. We need to know if they are expansive or infiltrative, because infiltrative mucinous ovarian cancer have a worse outcome, have more lymph node metastases, and can have more systemic metastases. So the type of surgery might change according to the histologic subtypes, and in infiltrative subtype, we need to be more aggressive, and we need to consider a more pelvic and parotid lymphadenectomies. So in conclusion, first-line treatment in ovarian cancer needs to be individualized according to stage, COG, histology, and germline and somatic BRCA mutational status. The BRCA mutations, both germline and somatic, needs to be incorporated early. We need to tailor treatment according to BRCA mutations, and it's an important stratification factor for future clinical trials or current clinical trials. So this is an important information that we need to have early for our patients. Frontline treatment of ovarian cancer needs multidisciplinary management. And although standard of care is generally saying cytoreductive surgery with the goal of ER0 and 6 cycles of carboplatin and paclitaxel, other treatments need to be having consideration, such as bevacizumab in high-risk subgroups or stage 4, olaparib in those with BRCA mutations, and of course, clinical trials. And I would like to thank my team, my GoGoGyney team in Princess Margaret, and for making everything possible, and for the care that they give to our patients. And thanks everyone for listening to me. My email is there if you have any questions. I will be happy to answer them. Thank you.
Ainhoa, thank you very much for this wonderful presentation on behalf of WeOncologists and ESO, and really on behalf of all of our colleagues out there. This was very much needed, and also something that I'm sure many of our viewers are going to enjoy. So we thank you very much for this wonderful opportunity, for taking your time on the weekend. And we will leave you so you can enjoy the rest of your weekend. So on behalf of all of us, thank you very much.
Thanks, Yale. A pleasure. Bye. Hope to see you soon in ESMO.
Will do. Bye.